Daymark Health is a value-based care cancer company. We partner with health plans. We do in-home and virtual supportive oncology services for patients receiving active treatment for cancer in partnership with their own providers. But rather than getting paid to do more or to increase the intensity of care, we actually get paid to do things that are consistent with our patients' goals of care.
Welcome to Boombostic Health, where we challenge the business of healthcare and explore bold ideas that drive meaningful change. Hey everybody, welcome to another episode of Boombostic Health. I'm joining from the podcast studio here in the city of Chicago. I've got Dr. Justin Bekelman joining from Philadelphia, right?
You got it.
Which is another fantastic city in our great nation. I always love visiting Philly. We got the Philly cheesesteak. Next time I go, I need to ask for your opinion on that because the last time I went, I wasn't super impressed with the Philly cheesesteak.
Alejandro's, there it is.
Okay, that's
my
the
son's.
place.
My son's going to debate that, but there it is.
Okay.
My daughter probably also will have an opinion here.
What's your son's pick?
He'll go either way, honestly.
Okay.
There's one called D'Alessandro's. There's our local place right around the corner from us, which is McNally's. Pretty awesome.
Okay, awesome. Well, I'll hit you up, and when you come to Chicago, let me know. I can guide you to the best steaks and pizza.
There we
in
go.
Town. Which is a little known fact that Chicago pizza actually isn't deep dish. Like actual authentic Chicago pizza is more of actually a thin crust, which is crazy. Dr. Bekelman's on a mission to improve cancer care, which is obviously something that affects all of us in some way, whether it's our friends or family members or ourselves personally. Public service announcement: if you haven't had a colonoscopy and you're 40 or older, that's my view. I would start at 40. My mom died at 56 of colon cancer. And I think the guidelines now from insurance generally are 45. And I know very young people that have gone in and had very seriously dangerous polyps removed, even in their 30s. And you wonder, those can turn into cancer by the time you are 45. So good idea. But unfortunately, we don't always prevent cancer. A lot of people are dealing with it. And it's a very difficult process that's complicated. It's overwhelming. It's difficult for the patient, for their families. And you've co-founded this business, Daymark Health, that has been created to go with a value-based approach to dealing with cancer care. Justin, I would love to have you share a bit about your background and just give our audience a better understanding of how you're doing this and, importantly, who pays for it. So I'll turn it over to you.
Yeah, Bradley, thanks for having me. Great to be on the show. Thanks for that public service announcement. Super important to participate in all the screening and prevention you can do for cancer, including colonoscopy. So thanks for that. Sharing things like that personally does affect people and how they think about their own health. So Bradley, thanks for doing that. I'm an oncologist. I've been practicing for over 2 decades, mostly at the University of Pennsylvania health system. I'm a prostate cancer specialist, so a men's health doc as well. When I wasn't taking care of patients, I was leading innovation and value-based care programs across our health system in Philadelphia. If you root for the Phillies, there's Penn Medicine near you. But you know what? Even with all that impact, all the advances in American cancer care over the last 50 years, still patients are falling through the cracks. It's bad enough to get cancer. It's even worse to then face a healthcare system that, just by the design of it, unfortunately still provides suboptimal care. So I left Penn Medicine about 1.5 years ago to start this company now, Daymark Health. Daymark Health is a value-based care cancer company. I'm looking forward to sharing more with you about it.
So you actually discontinued your practice to go run this full time, or do you still see patients?
I still see patients as well. It's a small portion of my time because leading this company, I'm the chief executive officer, co-founder of Daymark Health. It's a all-consuming full-time job. But this has been what my career's been about, Bradley, from day one, is how do we change American cancer care to be available, accessible, and provide world-class care to everybody, regardless of their zip code.
Okay.
I left Penn Medicine not only because I thought there was an opportunity to continue to sort of push that ball up the hill around American healthcare, but also because my patients inspired me to do so. Despite the incredible advances we can bring to care, patients still fall through the cracks. So creating a third-party disruptor, a new entity in the healthcare ecosystem that took care of patients in the way that Daymark does was just so essential, and that's why I left. That's why I left Penn.
And Penn is obviously a fantastic health system, and what a great place to develop your knowledge of the holistic experience for the patient. There's always a key consideration when you talk about any enhanced service, which is how does it get paid for? And in value-based care, we see an opportunity to incentivize things that actually make healthcare cost less, to create more value through improving the way that care is handled for a patient. That's how I think about value-based care versus traditional fee-for-service. So when you talk about value-based care in this construct, can you elaborate a little bit about what you actually mean?
Yeah. There's no perfect payment model, Bradley, right? Fee-for-service, it's one payment model. It's dominant in the United States. The downside of it is that it incentivizes overuse. So we need clinical guidelines to prevent overuse, right? Because every time you do a procedure, you get paid. Every time you have a hospitalization, you get paid. In value-based care, it's like a lump sum payment. And so under that model of payment, you get a lump sum. No longer do you have the incentive to overuse, but there can be incentives to skimp. Right? That's the concern on value-based care. How do you prevent that? Again, you go to clinical guidelines to do tremendous care. So being a clinician executive of a cancer company, when I looked at the model, we did all this incredible work in our health system to drive down total cost of care. But the single party that benefited economically was the payer. So all this work that providers are doing, whether it's in the academic medical systems, the integrated healthcare systems, the community practices, to make healthcare costs go down, in the fee-for-service system, there's no way for that economically to accrue to the people on the ground doing that kind of care. So I left Penn to create that structure. So as a third-party market solution in this sort of healthcare ecosystem, Daymark Health is a value-based care cancer company. We partner with health plans, and we do in-home and virtual supportive oncology services for patients receiving active treatment for cancer in partnership with their own providers. But rather than getting paid to do more or to increase the intensity of care, we actually get paid to do things that are consistent with our patients' goals of care. So if their goal of care is to attend to their mental health services, right, to attend to their mental health, we know we can do that through cognitive behavioral therapy. Well, that's part of our model, right? We don't have to go through the sort of rigmarole of, oh gosh, you got to refer it to this provider. We're not sure they take the insurance. Oh gosh, we don't have enough people who understand how to do cognitive behavioral therapy for patients with cancer. We actually know that that works. But in the model that we present, Bradley, we're able to actually provide all these supportive care services that are under-reimbursed or never reimbursed as part of the fee-for-service system.
Okay. And are you entering into shared savings arrangements with the value-based health plans?
When we built Daymark Health, we wanted to bring in like the best of oncology, like a dream team of oncology with the best of value-based care. What's amazing about the value-based care industry today, it's been 15 years, maybe even a little bit more, nearly 18 years since the Affordable Care Act in 2008, 2009, that really this version of value-based care comes from that. And so we've had in primary care a number of companies that have gone through value-based care, learned a ton of lessons. Some companies survived, some didn't. Then there were the chronic condition, like Concerto Care, Landmarks of the world. Then there were the kidney companies, right? Now it's happening in oncology. Now it's happening in the specialties.
Okay.
So we get to benefit from all those lessons learned in creating good contracts that allow us on behalf of payers' members to deliver terrific cancer care.
Okay. And so a patient who's interested in this, can they reach out to Daymark and say, hey, I would love to have this service? Or do they need to be inside of a health plan that you've already partnered with? How does that work?
Daymark Health partners with health plans first, right? The health plans, it's the basic idea. Look, patients with cancer typically receive their care in an outpatient setting. So they go in for their chemotherapy, or they go in for their daily radiation, or they have surgery. And then they go home. And so patients have to spend 8,500 hours at home, not in front of their docs. And the question is, how do you take care of them when they're at home? Your question is, well, how do we get in touch with patients? Well, when we work with a payer, we could say, well, under the fee-for-service system, hey, can we charge you for a home visit to take care of this patient who's having nausea, or who's having, his volume down, is having some headaches, or is having a little wobbly? Can you pay us for a home care visit? That'd be the fee-for-service system. But instead, under the value-based care model, patients get our services as a benefit of their health plan at no additional charge to them 24/7. Under that model, we can go into the home. We don't even bill a CPT code, Bradley. We can go into the home and do what's important to those patients because, again, under our model, that model pays effectively to prevent complications rather than to manage complications. And that's what that home visit would do. So for patients to get in touch with us, we'd have to be located in the market and working with their health plan because we come as a benefit of the health plan.
Makes sense. So within the value-based care model, a lot of our viewers are business people in healthcare that are looking to make their way from fee-for-service into value-based care. And in your case, if I'm understanding correctly, there's let's just use simple terms. There's a budget that's provided for the type of cancer that needs to be cared for. How is that determined? I'm sure there's a very advanced actuarial model somewhere that's come up with these numbers, but what's the determining factor that says how much you have available?
Absolutely, Bradley. We actually don't work under a global budget scenario. That's not the model that we have. We effectively do an episodic capitation model. So one way to think about that is we charge the easy way is with a payer, we would charge a PMPM with a return on investment, and that type of contract is familiar to payers. Another way that we might contract is we might look at the cost trends in the market, see what the baseline is in 2024, understand what the expected trend might be in 2025 for cancer, and then our impact is measured based on the difference between what we observe in the market after we're in there versus what the expected trend might be. In that scenario, we might share savings, right? I reference all the companies on whose shoulders we stand because those are sort of tried and true value-based care models. Right. I think what's different in cancer today is a few things. One is that cancer has an unrelenting upward trending cost. Even effective drugs continue to be highly expensive. And they're often one-off drugs. There's no competitor. So creating pricing pressure on the drugs is very difficult. The second, oncologists, whether they're in community practice, independent practice institutions, they're a bit in the corner, right? They've been bought up, merged, right? MSO'd, right? Mm-hmm. They're just trying to get through the day, and all this business attention has been focused on their practice. Put that in the context of the inflationary pressures, workforce pressures at big integrated care delivery systems. It puts tremendous pressure on care delivery. And then the last thing that's so important is the cost of cancer care the per patient per year Medicare cost of cancer care probably $60,000 to $80,000 a year for a patient on active treatment. The average cost of a patient sort of in a primary care ACO, maybe it's 10 to 15,000, right? So it's 5, 6, 7 times the cost, right? Because it's such a complicated illness and because the therapies are expensive and because there's a bunch of suboptimal dealing with a bunch of the side effects of the cancer and side effects of those treatments. So the opportunity for us as a value-based care company, the reason why it's such an awesome opportunity in cancer is because the spend is large and it only affects a small group of patients. So we can devote an intensive care model of both home-based care as well as virtual care, partner with providers to actually right the ship, provide that whole patient health care. And I think that's what makes cancer particularly suited to value-based care.
Right. That's fascinating. That is really fascinating. Because I have heard a lot of people talk about the difficulty of a complex disease state like cancer in a value-based care model. So the way you described the episodic capitation approach, where you're able to put some parameters around what are we doing and how is that delivering an improvement in the experience for the patient, but also importantly, ultimately in the cost overall. It's, it's hard for me not to relate it back to my own experience with my mother's stage 4 colon cancer diagnosis. And she was in the Cleveland Clinic system, which is obviously a very high quality system, amazing physicians there that were not always as coordinated as it would have been ideal. And it wasn't really their fault. It was just the way things were set up. So at each little silo, you'd have an individual there who was highly qualified doing the best they could, but they just really didn't know her at all. It was very tough to watch that. And it seems like what you're describing, you become that. I played football, so I think about, football metaphors, but you become the quarterback, I think is what I'm hearing, where you are working to ensure that this individual has the right things happening at the right time. Is that fair?
We're more the connective tissue.
Okay, the connective tissue.
And I'll tell you why that is.
Okay.
Because patients adore their oncologists. And we respect that relationship. Not only do we respect that relationships, patients really trust the doc who's giving their therapy. It's a life and death situation. So we borrow the trust that patients have in their doctor and we extend it. We're the connective tissue.
That's a great way to put it. Yeah.
Because what happens, despite the great doctors where your mom, despite their great intention, the system doesn't work.
Right. Yeah.
Like, you're obviously, you're a podcast leader and executive yourself. You fly. We were talking about it before the podcast. When you get your seat on the plane, you spend a lot of time figuring out where that seat is. You look at it, make sure it goes back a certain number of inches. Maybe it's next to the aisle. You make sure there's like a plug for it. There's one question you never ask, and that's who's the pilot. But when you go into the American medical system, there's only one question you ask, and that is who's the doctor. That's because the system around the doctor is suboptimal. What Daymark does is it partners closely with the patient's own oncologists so that we can hold that patient in a safe net of care that addresses the patient's clinical, behavioral, and social needs, both virtually, right, through bidirectional texting. We're highly accessible. Patients love, they're literally delighted talking to us, but also by providing care in the home. There used to be 2 sites of care, the clinic and the hospital. The pandemic showed us all that there are now 4, clinic, hospital, home, and virtual. We complement the work that's being done in the clinic and the hospital by providing a holistic solution in the home and in the virtual space. From the perspective of the payer, we're now better able to manage the total cost of care, whether it's cancer related or not, during that cancer episode. From the perspective of the provider, we can take care of all those needs, whether it's nausea at 5 p.m. after the team's gone home, whether it's mental health services, whether it's social needs. We can do all those things so that those doctors can do what they do best, which is give life-extending treatments to their patients. And from the perspective of the patient, when a patient is coming out of that room with that incredible doctor, but is like, you know what? I didn't quite understand what she said. They can just call Russ and we'll help explain it. And we'll do so coordinating with that doctor's team. It creates that holistic model that's not incented by the fee-for-service system and is basically absent across the American healthcare landscape for cancer.
Yeah, it's as a technology, as a technologist and somebody who's been working with computers and networks and code for a long time, it's almost as if it's like how the computer was before there was an operating system that actually coordinated all the pieces. And so you have to actually coordinate all the pieces. So the only people that could use a computer before Windows and Mac OS and all that were people who were technical and they could create the way for everything to work together. And then they got kind of a broken, not very useful outcome. And in the case of today, we've got, these massive networks that are all designed to coordinate with each other to get the end objective met. And it seems like maybe that's a better way to think about it, because you're right. The oncologist is the lead on this, and you're providing
the oncologist is the quarterback. We provide that connective tissue. We provide those coordination services. Those are essential, of course.
Right.
What also is necessary, though? It's also necessary that a value-based care supportive organization like ours can take action, can actually prescribe. If a patient needs radiology, we can prescribe that MRI. If a patient needs an opioid rather than a steroid, we can prescribe that. If a patient is having trouble breathing at home and is on with a virtual case management for cancer program, and they're saying, gosh, it sounds like you need to go into the ED, we can be in that patient's house and actually realize that the line is kinked. You can only do that if you go into the home. We can do catheter management. We can do infusions in the home. So it's the I think a really important point of view, and what I think puts us on that, puts a number of value-based cancer care organizations on a trajectory to success, is that it's not just about coordination. It's about being able to take action in partnership with the incumbent medical groups in the ecosystem, whether, again, it's the integrated health systems, the community practices, the academic medical systems, et cetera.
Right. That makes a lot of sense. So how many patients are actively within your care program at this point or at any given time?
Yeah, our current model is with an anchor partner, Blue Cross Blue Shield of Rhode Island. That plan has 400,000 members. We have their entire book of business. We take care of roughly 1% of the population at any given time.
Okay.
That's the number of patients in a given population that are in a given sort of payer population across Medicare, Medicare Advantage, commercial book of business, fully insured ASO. That's on average about the number of patients that are being actively treated for cancer.
Right. Okay. That's fascinating. Do you have a story you can share? I think that brings it home for people. There's the business model you've developed and a really good concept here. Can you think of a patient example, and you don't have to offer any name, and divulge anything personal, but I think it'd be cool to hear something that would help the audience really, take to heart why this is so powerful.
Absolutely. I mean, there's a few examples I'd love to be able to share. I think one of the most important patient stories relates to one of our members who's actually been profiled now in the media. His name is Stephen. He's a tremendous partner of ours. He was a patient of ours who was diagnosed with colon cancer. And what he said in one of the media opportunities he shared was, cancer doesn't stop at 5 o'clock.
Right.
And being able to have a program, a team of nurses, nurse practitioners, a medical director who's in the field, be able to visit him at his home, do a number of medical procedures that he needed, but also listen to him, attend to, his clinical needs, but also mental health needs, social needs, give him the space from the comfort of his own couch to be able to share his story. It's that kind of powerful patient bond that ends up moving, obviously, care for that patient, but also improving experience, improving quality, and ultimately having a chance to do care that's consistent with patients' goals of care. What we also know in the world of cancer is that if care is consistent with patients' goals of care, total cost of care can go down by 15 to 30%.
It's remarkable. It's probably relevant to mention, and thank you for sharing that story. I love that phrase because cancer doesn't stop at 5 p.m. Like that's a really palpable way to explain the situation and the value you bring. One of the areas we've found in one of our portfolio companies that's an opportunity with value-based care is prescribing generally, especially when you have people who are polychronic and pretty sick in many ways, seeing lots of specialists. They end up on 14 different meds that some conflict with each other, some don't work with their genetic profile. So this company we have, DecisionRx, is similar to what you're talking about. We partner with the health plans and folks like United and Humana and others, and the service constantly is scanning using technology all of these prescriptions, and then it uses algorithms to come up and say, this is a high-risk person based on the meds that they're on. And there's this process that happens. But what strikes me and what you said is there's a concierge-style pharmacist that's actually in our service offering that engages and works with the quarterback, who's the primary care doc, to get that patient on optimal meds. And then we are able to measure at DecisionRx the impact of that. And it's just fascinating. It's like somewhere on the order of $3,600 per intervention in savings per patient per year. So, that's $3,600 times thousands of people.
That's right. Bradley, I just want to, it's funny, people sometimes when they hear about what we do, because it's such an intensive model and there's so much back and forth with patients, our NPS score is 89, but it's not just that number. 50% of patients across our platform respond to our NPS measures, which is 2 to 3 times what it is in the industry, which means that not only are patients delighted with the care, they're actually eager to tell us about it. But some people are like, oh, that's sort of like concierge medicine. And I say, no, it's how medicine used to be. Right. And so your medicine, people may forget, but, home visits were part of what was done, right? And being able to talk with a clinician for, 75 minutes about not only your cancer, but your fears about the future and what's your wife going to do and what's going to happen to the kids. And those moments are so essential and are effectively disincentivized in the fee-for-service medical system. But in a value-based care model where understanding goals of care and driving forward better experience actually yields total cost of care that's more optimal, it all economically fits. I think it's also important to recognize that we design our contracts in a way such that as new innovative medicines come on board, we want to continue to promote those. If there are great medicines that are expensive, which is usually how it works in cancer, those need to be made available. It's the so-so drugs that are also expensive that honestly are crowding out the ability for us to pay for the effective drugs. It's those kinds of drugs that we need to ask patients and their doctors questions about. But in a value-based care model, and just going back to this idea of skipping, we've been able to design contracts that are not only patient-centric and payer-centric, but actually also promote the economic interests of the providers that we work with. And I think that's what's creating this synergy that's making our first year in Rhode Island. We've now been able to analyze our results, and we're driving 7% reduction in total cost of care. We're driving tremendous reductions in preventable cancer admissions. It's a combination of that real strong patient engagement with real strong provider engagement.
Mm-hmm. Well, it's a true pleasure to learn more about what you're building, and I know you're just getting started in terms of where you are relative to the opportunity that's out there. But congratulations on having proven the impact and being able to not only deliver on the experience that these patients deserve, like cancer doesn't stop at 5 p.m. Those are very powerful anecdotes. But the thing that really makes this kind of an opportunity exciting is the fact that you've measured the impact, because that's what then gets the health plans to say, why aren't we doing this? And that's very rare in value-based care, as you know, that you get that far.
That's right.
Having been an entrepreneur for my entire life, I have such a huge amount of appreciation for what it takes to go from 0 to 1, and then to have that day one mentality every single day where you bring that same energy today that you had the first day.
Yeah.
And I can tell you're one of those rare individuals, and just congratulations on what you've built. And I hope the model you've pioneered or have sort of proven here becomes the standard, because it should. This should be the way that cancer care is managed.
Appreciate you very much, Bradley. Thanks for your kind word. It's been a pleasure.
For sure. Awesome. Well, thank you everybody for being here at Boombostic Health with Dr. Justin Bekelman, the co-founder and CEO of Daymark Health, who is ensuring patients have the in-home services required to have the best possible experience and outcome with their cancer care. We'll look forward to seeing you next week. Have a great day.